Okay. Um, the topic for today for me is left ventricular rupture following mitral valve replacement. And rupture of the left ventricle following mitral valve replacement is infrequent, but it's a dreadful fatal complication, and it occurs in about 14 to 18% of patients who are operated upon. It was first reported by Roberts and Marrow in 1967, who described the autopsy findings in two patients. Fortunately, it is less often seen than 15 to 20 years ago, but nevertheless, it carries a very high mortality of 75%. And if there are any new developments in the prevention and management of this dreaded complication, it's welcome. The types of left ventricular rupture, there are three types: type 1, type 2, and type 3. Type 1 is the commonest type. It's located in the atrioventricular groove. It occurs in patients who have a very heavily calcified mitral valve annulus. It occurs in patients who have bacterial endocarditis with mitral valve annular abscess, and resection of the posterior leaflet and chordae with placement of subannular sutures for valvular replacement results in subsequent trauma, hematoma, and rupture. And also an improper inspection of the LV posterior wall after mitral valve replacement by lifting the heart and using the left AV groove as a fulcrum can result in rupture. Type 2 occurs at the base of the papillary muscles, and this is due to excessive resection of the posterior papillary muscle with local hemorrhage and rupture. The predisposing factors for a type 2 rupture include intrinsic myocardial disease, whether ischemic, rheumatic, or infectious origin, or a technical injury to the left ventricular wall during papillary muscle resection. And type 3 is located between type 1 and type 2 and is most often related to a posterior LV wall trauma, and this is due to a high profile or a large prosthetic valve, often in combination with a small LV cavity. And when we use a bioprosthetic valve, there are injuries to the left ventricular wall are known to occur due to the penetration of the valve struts in the posterior myocardium. And this is a diagrammatic representation to show you where the type 1, type 2, and type 3 ruptures are present. The type 2 and type 3 LV ruptures have been virtually abolished primarily due to the following technical reasons. The prevalence of mitral valve repair versus replacement is one of the reasons. The preservation of the mitral valve leaflets and papillary muscle attachments during mitral valve replacement. The struts of the new bioprosthetic valves have a lower profile and are held in an inward position by sutures, thereby lessening the possibilities of trauma to the posterior wall. And the recommended techniques of lowering the prosthetic device with strut sutures in place is a must and should prevent the penetration of the struts into the posterior myocardium and the abandonment of a high-profile prosthetic valves. And always the awareness of this problem and improved technical guidelines have also lessened the incidence of this complication. And the timing of these ruptures, early tears occurs in the operating room before or after weaning the patient from cardiopulmonary bypass. Delayed tears can present hours or days after leaving the operating room, and late tears appear days to years after mitral valve replacement and usually present as an LV pseudoaneurysm. The early rupture comprises 2/3 of LV ruptures following mitral valve replacement. The mortality rate in these patients approaches 50% despite early treatment. And what are the risk factors? The risk factors include the pre-existing intrinsic myocardial disease, which we just discussed. Preservation of the basal chordae of the posterior leaflet is important to prevent LV ruptures. And most of the ruptures are attributed either due to technical maneuvers in the operating theater or to stress injury produced by the untethering of the left ventricle through removal of the mural leaflet of the mitral valve. The hypothesis, which is proposed by Hobbs in 1980, was the untethered loop hypothesis, based on the autopsy findings of 7 patients, seems to be the most reasonable explanation. And this concept considers the supporting structures of the posterior left ventricular wall to form a loop. And the outer portion is composed of longitudinal muscle fibers in the left ventricular wall, while the inner portion of the loop consists of the papillary muscles with a chordae attached to the annulus of the mural leaflet. And thereby division of this mural leaflet chordae can seriously weaken the posterior left ventricular wall. The potential harmful effects of intraoperative hypertension in this context is also one of the reasons. Fortunately, the coexistence of aortic valve disease seems to have a protective effect because of the thickened or hypertrophied ventricular myocardium is resistant to tearing. And the pathogenesis of a type 1 rupture is worse than a type 2. However, a clear separation between this classification is not always possible. Diagnosis: the clinical representation is either unstable hemodynamics after cardiopulmonary bypass weaning, or failure to wean off cardiopulmonary bypass. You see a massive bleeding from the left ventricle in the operative field or through the chest tubes, ventricular arrhythmias, or an abrupt hypotension, while pseudoaneurysm is a delayed presentation. Sometimes you see a huge dissecting hematoma with left ventricular failure, or a large sac of pseudoaneurysm with its expansion can compromise the lumen of the circumflex artery to produce a myocardial infarction. And these potential complications of left ventricular pseudoaneurysm include LV failure, thrombus embolization, or rupture of the aneurysm, and death. An incidence of 0.8% of LV pseudoaneurysms occur in cases after mitral valve replacement. Treatment: the difficulties in repair of a left ventricular rupture after mitral valve replacement are because the left ventricular muscle is friable and cannot hold sutures well. There's poor exposure and visualization of the anatomy of the rupture site. The technical inaccessibility of placing sutures through and through the ventricular wall, which is usually near the atrioventricular groove and circumflex coronary artery. Difficulty determining the precise location of the rupture is usually faced, and the actual perforation can actually be distant from the site of obvious hemorrhage. And although local focal perforations have been repaired in few patients by external methods alone, the external rupture may only represent the tip of an iceberg, giving little clue to the extent of the underlying ventricular rupture. And several technical considerations have emerged as important factors in the prevention of left ventricular perforation. And these are: all posterior mitral valve chordae should be preserved if at all possible. Avoidance of extensive excision of calcium when it extends through the annulus, particularly in the area of the posterior medial commissure. Careful and accurate sizing of the valve to the body of the annulus, and also the area of the ventricle immediately underneath the annulus, and accurate and judiciously limited papillary muscle excision. Avoidance of excessive traction on the ventricle when adhesions are still attached to the left atrium and the AV groove, and avoidance of placing a valve strut near the thin attachment of the atrium to the ventricle. And if a tear occurs during bypass, should be reinstituted if at all possible, and repair should be performed on a decompressed heart. And bypassing of the distal branches of the circumflex artery and reduction of the afterload with an intra-aortic balloon pump may be helpful. To avoid pressure overload, the general consensus is that repair should be accomplished with cardiopulmonary bypass on a decompressed heart. And after load reduction, these critical situations, an intra-aortic balloon pump will definitely be beneficial to avoid tension on the left ventricular repair and helps the friable and edematous tissue to heal. And the basic requirements for successful repair of the tear are closure of the full extent of the repair, placement of sutures into a healthy myocardium and not into the injured edematous tissue in the immediate vicinity of the tear, and sparing the left circumflex coronary artery and its major marginal branches, removal of the prosthesis and accurate identification of the site of tear, and repairs on cardiopulmonary bypass may have a better chance of success. There are several types of repair, and there could be an external approach, which is complicated by the fact that the internal disruption site and the external bleeding point are at different locations. And using the external approach, the circumflex coronary artery is more prone to injury, as I've just alluded to. And the epicardial approach can be approached via a left thoracotomy as well, and epicardial tissue sealing with Teflon patch and glue. The internal method is considered to be the safest and most successful approach, even though previously placed prostheses have to be explanted during cardiopulmonary bypass. And then you have these endoventricular repairs, where there are various techniques of posterior leaflet technique, of a standard pleated repair technique, left atrial appendage flap technique, atrialization of the tear, endocardial patch technique, transaortic patch technique, partial translocation, and obviously autotransplantation. And these are the highly technical ways of trying to close this dreaded complication. And what are the results? The surgical repair of the rupture with and without the aid of cardiopulmonary bypass results in 50% and 7% survival respectively. With the use of cardiopulmonary bypass, external repair was followed by 67% survival, and internal approach was followed by 27% survival. Devini and McKenzie used the left atrial appendage to cover a type 1 rupture and sutured it to the left ventricular wall below the defect on cardiopulmonary bypass and cardioplegia. Treasure and associates placed mattress sutures from the sewing ring of the prosthesis through the ventricle below the tear, and these sutures were tied over the epicardial surface over Teflon felt edges on cardiopulmonary bypass and cardioplegia. Autotransplantation of the heart is an excellent method to rescue patients who develop left ventricular rupture following mitral valve replacement. Of course, cardiac autotransplantation for the treatment of left ventricular rupture was first reported by VAL and Campanella and AL. The left thoracotomy approach is a known way of trying to repair once you've come out of theater. And the other methods are an off-pump surgery with the use of Teflon patch and glue. But it has been shown that when this complication has happened postoperatively in the ICU, the best method is to be a stenotomy could be reopened in the ICU, and whenever an epicardial hematoma and massive bleeding from the posterior wall of the left ventricle is seen, glues have come in place to help, but the best way to suture these wounds is to go back to theater and do it under controlled setting on cardiopulmonary bypass, on a decompressed and an arrested heart. So these are the types of repair, and when this rupture is diagnosed and other bleeding sites have been excluded, these patients are left off pump, and then you can check it after protamine has been administered, and a diagrammatic representation to show you how a prosthetic valve is removed and then resutured in place with a huge Teflon pledget, as I said, to make sure that the left circumflex artery is not compromised, and in case if it is compromised, to bypass it using a saphenous vein graft. And an LV rupture following mitral valve replacement on a stable and a hemodynamic unstable patient described in an algorithm form. And so the take-home points for this presentation is left ventricular rupture following mitral valve replacement is encountered more often than reported, with an approximate incidence of 0.5% to 2%. The prognosis is ominous, particularly that of the delayed type, but with certain precautions, the risk of this complication can be minimized. and careful excision of the valve, particularly the posterior leaflet, using a properly sized valve, limiting the sutures to the annulus only, avoiding excess tension on the papillary muscles during excision, and gentle elevation of both the left atrium and the left ventricle for deaeration are some worthwhile precautions. Thank you very much for your patience and for giving me this opportunity to do this presentation and take any questions if there is any.